So they should be ready, huh?
This decision is two other different hospitals. Okay. It's not Asa Medical Center, so we don't have any change in the cases simultaneously, consecutive. The first Catholic and the other one is yeah. We don't have a change yet.
Change the first line.
Yes.
What do you know?
It's maybe Catholic first, and we finished some first case, and the second one is South Legion University. Yeah, we don't have any change. It's not a one center. Yeah, two other center.
Do you know what to know?
It looks like we have Adrian Chung, Helen, and then I don't see.
The last one.
No, it's like not.
Yeah. What about Tetsuya Tabora?
Something probably second. I guess in second.
No, we have 9 people. With us, there are 10 discussants, right?
Good morning.
Good morning.
Hi, I'm Murat Tuzcu. My co-moderator is Dr. Yan Ye. And then let me introduce you our distinguished panel, if I may. Adrian Chong and Elena Elachinov, Dr. Hayashida, Dr. Won Yang Kim, Dr. Hanchel Lee, Dr. Se-Wan Lee, Dr. Lefebvre, Dr. Walters, Darren Walters, and Wojciechowski. We welcome you, and then Mike is yours.
Can you hear me?
Very well.
Hello everyone. I am Ki-Yuk Jang, interventional cardiologist of Seoul St. Mary Hospital. Good to see you again, Dr. Kentaro and Dr. Kim and Dr. Lee. First of all, I'd like to introduce my team. Just next to me, Dr. Yoon Seok-go. The second guy is Dr. Byung-hee Hwang. And then today, tea is going on by Dr. Ubek Jung. And then the anesthesiologist is Dr. Ho. So the today case is very interesting. We prepared several discussion points. Before going on topic, the Dr. Gu will present the case briefly.
Okay, let me introduce patient information. Patient is 84-year-old female. Chief complaint was aggravated dyspnea, DIA class 3 dyspnea. In past history, she underwent PCI 10 years ago, and 5 years ago she suffered ischemic stroke and underwent carotid artery stenting. So STH score was 7.4%. Next. She have hypertension. Next. This is transthoracic echocardiography. Severe aortic stenosis. The Vmax is 4.5 meter per sec. Mean pressure gradient is 61 millimeter mercury. Aortic valve area of 0.8 or 0.9. Would you introduce T finding, Dr. Jung?
Okay, this is aortic valve of TEE. So there is several calcified nodules on non-coronary cusps. So paravalvular leak may occur around this area. So to reduce paravalvular leak, we need to decide whether to pre-balloon or not. So as you can see, T, the RCC and NCC has very severe calcium, especially RCC has a lot of calcium. So please understand this. Next.
Next. This is a CT finding. The perimeter is 76.2 millimeter.
We do not.
and-
Okay, here we go. Go ahead.
Okay, previous area is 4.18 square centimeter. Next. This is calcium distribution. The calcium distribution is relatively even among three cusps. However, the amount of calcium is moderate to severe and relatively horizontal aorta. However, there was no calcification in LVOT. Next. This is peripheral CT angiogram. The iliac artery and femoral artery is sufficient for transfemoral approach. However, the left EIA, there is a severe calcification, and the device is, we are going to TAVI device by right femoral. Next. This is coronary angiogram. We undergo coronary angiogram yesterday. The moderate stenosis in proximal to be the LAD, and moderate stenosis in proximal circ, and severe stenosis is distal circ. Next. This is FFR, the result of FFR. The FFR of LAD is 0.77. The FFR of OM was 0.68, and FFR of circ was 0.79. Next. Okay, we plan to TAVR by Evolut R 29 millimeters. Next. This is our discussion point. First, whether a strategy is better, on-site PCI during TAVI versus TAVI after elective scheduled PCI. Second is the relevance of FFR in patients with severe AS. So this main discussion point. This patient have very severe amount of calcification of three cusps. In the case, and Evolut R, which strategy is better, pre-ballooning versus direct stent implantation? Okay. Finally, how to make coaxiality during implantation in horizontal aorta?
Before the procedure, we are planning minimalist TAVI procedure. However, the patient has a lot of calcium in right coronary cusp and non-coronary cusp. So we change our policy because we are concerned about the paravalvular leak after implantation. So right now she underwent general anesthesia and T was inserted. In this patient, 2 points. You can believe FFR in patient with severe aortic stenosis, and do you prefer pre-ballooning in patient with severe AS who are going to receive the Evolut R, not Sapien 3? So my discussion point is like this. Please, the panel discussion, and let me know.
Well, that's great. Thank you very much for the elegant presentation and already making our life easy with pointing out the discussion points. Indeed, perhaps we can even add one another discussion point that do we need to do the revascularization before proceeding with TAVR. So let me ask the panelists to comment on the issue of coronary disease and if they think that PCI should be done, should it be done at the same stage or should be staged? Darren, what would you do?
Well, if there's significant proximal epicardial stenosis, I think we routinely revascularize them ahead of the TAVI procedure. It unnecessarily complicates the TAVI procedure, affects the whole flow of the case list for the day. So we find it simpler to electively revascularize where we need to, and then implant in a staged fashion. Prefer not to try to revascularize after implantation of a stent, particularly through the side strut, say, of a core valve or other. You can't always be guaranteed of good access. And so I think if you know, like this patient, they have coronary stenoses, it's very simple to schedule this in, have it done as a part of a preparation for transcatheter valve replacement. While it is possible, and we have done combined procedures, it really does interrupt the whole flow of the patient for the day.
Any other comments?
Just one comment, maybe. Anyone?
I fully agree with what was said just before. I think it's when we have critical lesion of the proximal vessel, I always treat it. We have not seen the lesion, so I think it's very important also to see if it's critical or not. But looking at the FFR, it looks very severe. So I will do it before the TAVI, but not during the same hospital stay, in order to avoid accumulation of contrast.
I think based on the angiogram, just a quicker look at it, very quicker, but based on the anatomically, I'm not impressed with critical stenosis on the angiogram. And at our center, I think we changed a lot. So at the beginning, we are pretty aggressive to fix the coronary artery stenosis before the TAVI. But now we are most time we don't do it unless patient is symptomatic or significant, clearly have angina and also have a significant stenosis in the larger arteries, or the really like a big main artery with a critical stenosis. Otherwise, we are leave alone. Seems like there's no really issues.
Interesting. I tend to agree with Dr. Ye because we also say that if we don't have the FFR, would we jump and do things to the proximal AD and left main? And we probably wouldn't. So I think that's one thing, and we're going to discuss the FFR issue also. But let me ask other members of the. Is there anybody that's doing FFR frequently in the AS patients at the time of TAVR? What do you think?
I don't agree. Even in this, would you please do the baseline angiography, Dr. John? Would you please give us some coronary angio?
Baseline angio?
Yes.
Can you see?
A lot of some complicating situations. So if I were you, we just the little touch, very little touches of circumflex only. So what about those FFL values at that time was yesterday?
So yesterday, after finishing coronary angiogram only,
Yes.
I felt like only touching the distal circumflex region. But discussing with my team, the FFR should be done in this patient because proximal LAD and proximal circumflex region might be significant, even though it seems insignificant, maybe the intermediate region. But unluckily, the patient has very the severe FFR value under 0.8. So we are embarrassed. And we found, luckily, this year's TCT, last year ACC, some interesting report was, previous next slide. So is FFR reliable in setting of CVAS? Next slide.
Next.
Next slide is very interesting. if patient has FFR above 0.8, the value maybe not change very much. But patient has FFR value below 0.8, the FFR more aggravate after TAVI, after relieving aortic stenosis. So next slide. So the circulation CV intervention also speculate increased pressure afterload and elevate endodiastolic pressure and microartery dysfunction contribute more favorable FFR just before TAVI. So after reading this article, we confirm this FFR value is real. We have to treat the proximal LAD and proximal circumflex lesion. So our strategy in our institution is simultaneously perform the PCI and TAVI because we usually we didn't use a lot of contrast agent. Maybe the 100 we can treat the both three lesions, and then during the TAVI we mostly use the 50 to 20, so we can maximally limit our contrast volume on the 200 milliliter. So if patient is 3 vessel and very complex coronary artery disease, we usually schedule the PCI and then TAVI, but in this patient we decide simultaneous doing of PCI and TAVI. So actually we perform PCI.
Well, we better let you proceed because the time is getting short, so I'm getting a little nervous. Go ahead.
Yeah, okay. So panels, do you prefer pre-ballooning or direct implantation? So
So you are using an AL1 catheter, and then what kind of wire?
yeah, AL2.
AL2, AL or AR?
Not AR.
Really a heavily calcified heart with very marked calcification, nicely crossed.
We prefer after crossing aortic valve, we use Safari guide wire immediately. So don't change the pigtail, but sometimes we need a pigtail, especially in patient with small LV.
So this is a preformed wire manufactured specific for this tower cases. Its consistency is similar to an extra stiff wire. It's not a very, very stiff wire. And then it's nicely curved and sits well, and that's adverse events reported with this particular wire.
So we actually we decided direct implantation without pre-ballooning because we have some experience. The patient with more calcium, more calcified aortic valve, we prefer pre-ballooning and implantation. But in this patient, the calcium, in my experience, it is a little bit not severe, not very severe, but moderate to severe. So I prefer the direct implantation. After then, we assess the hemodynamically and the angiography and T, and then decide the post-deal. Okay, we go ahead with TAVI implantation trajectory.
Very nice. Yes, I think that maybe if the echocardiographer want to comment on that, simply because there is a little bit of a sigmoid septum appearance with a little bit of a bulge of the upper septum. That is one thing that comes to mind. And then, but otherwise, it looks you have a beautiful view that's perpendicular to the sinuses to work on. Yeah, go ahead and proceed.
Yeah, okay. So we already noted valve. Just a moment. We have the inspection of the whether node is okay. Just notate, and we confirm the pedal is okay. Very nice nodding.
That's a nice trick. So you look at it under fluoroscopy just to make sure that everything is as it should be, huh?
Yeah.
So your pigtail is in the non-coronary sinus. That will not only will be used for injection, but also is a good landmark to show the lowermost portion of the aortic root.
So we are advancing. When crossing the aortic arch, we do the LAO and then tension on the guide wire, and then the valve not touch the arch, and then smooth.
So you are very careful not touching the arch so that to minimize the risk of stroke. Now, can you repeat once more what size valve you are putting in?
The 29.
29 millimeter valve.
Yeah. The LAO 11, cranial 10.
So maybe you can tell us as you do this, where are your landmarks and what are you paying attention right now?
Yeah, it's the pressure is blood pressure is okay, and we under the three-cusp view, you can see this is three-cusp view, and then we change the direction caudally. Yeah, caudal. You can see one straight line.
Yeah, the
Can you see?
lowermost portion, yes, that's the opaque portion was somewhat oval. Now it's straight, that means that we are looking perpendicularly.
Pardon?
Yes.
Yeah. Can you the implant right now? Okay. So we just did some discussion. Or?
Yeah, I think that you're in good position. Your
Yeah.
blood pressure is coming a little bit softer.
Yeah. So this is actually the depth is 3. Depth target is 3 to 5. Now we start. We don't need pacing.
So you're just below the annulus, starting
Yeah, just
beautifully.
yeah, just-
Okay. And you let the valve
Just
to be
moment.
exposed.
NGO. Yeah, a little bit.
So pigtail moved up.
Yeah, pigtail. I deposition pigtail again.
There's quite a bit of angulation. Do you anticipate any problems here trying to get coaxiality with this valve? I think that might be one of the challenges here.
와이어 가이드예요?
Yeah, that's an important point that Dr. Walters brought up, is the sort of somewhat of a horizontal and angulation in the LVAO direction.
Yeah, the patient has a little bit the horizontal aorta, so the first of all the implant like this, and then the NCC side very high, and then RCC site deep in the LV, and then after 80% deployment, I change a little bit the layover, so the valve is maintain the coaxiality after layover, so we can decide after that.
So you're going to implant very shallow on that non-coronary cusp and then try and lay it over.
Because she has some the horizontal aorta and the less coaxiality right now.
Yeah. That's a problem for paravalvular leak, because if you really don't get that good coaxiality, you'll end up deep on the left coronary side with a leak around that portion of the valve. And this is one of the issues with self-expanding TAVI, in that it can be very hard in a horizontal aorta like this to maintain coaxiality and to get the same depth of implant right across the annulus. And of course that precipitates problems with paravalvular leak. Sometimes this can be corrected with using the balloon expandable platform, because it will tend to center itself and you can use a retroflex catheter to get better coaxiality. The other thing that can centralize better is a top-down deployment, like with the cementus valve. But the layover technique is particularly used in the Lotus, where you deploy and then you push forward and pivot. And that can help get a better coaxial valve.
How do you think about that?
That looks pretty good. Yeah. Don't go any further down, I suppose.
You can see that we've triggered some heart block there, and that may be, some pressure on the conduction system and the non-coronary cusp. So even at this point, manipulation in that region can cause temporary heart block.
Okay.
I think they stay pretty good right under the annulus, quite shallow.
Yeah. The bradycardia is actually working for you, really. It's giving you the time to deploy. You can see this problem here, where on the left coronary cusp you're quite a bit deeper than you are on the non.
At this moment, I will do the layover. After then, we decide.
Yeah.
와이어 좀 조금 밀어줘봐.
So your valve is functional there, and you still got it captured. So you could recapture it if you had to.
So you're just pushing your catheter in order to get it to the greater curvature, with the hope that this will lift up the left coronary sinus site.
It's a little bit deep.
The only problem with that strategy with a core valve is it may force a non-coronary deeper, and it may not pivot if it's trapped by the calcification.
Even though I started the NCC side very shallow, the final the relative deep, so I start recapture and repositioning again. Do you agree, or do you think it's okay?
Well, the question I want to assess is, do you have any paravalvular leak?
Unluckily, patient developed the complete AV block, so we stop and then recapture.
Well, any other comments from the panel?
Maybe we can push the wire a little bit more. Maybe the valve will go up a little bit.
Yeah, I agree with Kantaro. I think the level of the valve is good. And we know that at the end it will move by 2 or 3 millimeters. So I think at the end it could be perfect if you deploy at this level.
It's difficult to be for sure, but it doesn't look like the AR is, paravalvular leak is horrible. And then I don't know if you can do this better, because you're going to start pretty much as shallow as you started. So I would also think that you should go ahead, perhaps.
The only thing is to apply some pressure.
We are doing recapture.
Yeah.
If there's no AR and you've got toe, I would probably have left it and deployed.
Oh, okay. Just a moment.
Oh, you decided to recapture, okay.
Yeah, recapture. Yeah, test it.
So of course you can play also with
Yeah, we start
that particular
this
wire.
portion. Start.
Be coaxial with orifice.
So you moved it up even more. You're just by the annulus actually, and then now redeploying.
Yeah, redeploy. Just a moment. Stop. Test it. Oh, okay. 자,
You're just
go
barely in the annulus. That's as good as it gets probably.
ahead. Go ahead.
The risk starting this high
Yes.
is a pop-up, of course.
Okay.
Yes.
자, in this
Push hard at that time.
Sometimes you can
Okay,
start
time.
being more
Yeah.
coaxially by putting on the larger curvature and then applying pressure on the wire just to stabilize the valve.
Okay.
That required quite sensitive cooperation between the two operators. Yeah.
In the first case, it looked like the central leak was there, and now it looks more like PVL on the left side.
I think the position is a little bit higher, maybe 2 millimeter, and I think it's enough. If you try to be higher, it will be very difficult.
Yeah, that's not much of an AR. It looks like, huh?
Yeah, it's not good. The decay again.
Again, if there's no AR, I'd probably deploy.
Yeah, I think that I don't know if you can get better in this, huh?
It's just a problem with the technology, I think, in the
Okay.
way the self-expanding valve
자,
works.
프레저 올려주세요. 네.
You often end up, non-coaxial like that.
Yeah, in this patient, coaxial is the problem. So my strategy in this patient, the NCC side, zone 0, and then the pacing 120. After then, later time we lay over and then see what happened. Let's go. One more. Yeah, okay. 자, 와요. Okay. 자, right now the 110 facing. Start.
So, is there a limit, do you think, on how many times you can recapture
This thing is
reposition?
not
3
working.
times. 110. 110. 자, 테스트.
Of course, the company will always
Yeah.
say 3
Facing.
times.
In
자,
one
지금
case,
괜찮아요?
after fourth attempt, we had to remove the valve. It was not working
자,
properly.
testing.
So
Okay. 자, go ahead.
What about the risk
Slowly.
of stroke after multiple
Slowly.
captures?
Slowly.
Theoretically raised.
Pitching.
There's some pressure down now.
Yeah.
You don't want to pop out.
자, at this moment, I like prefer the
We,
Yep.
we analyzed
okay.
our experience with
Kissing.
recapture.
자, testing. Okay.
Yeah.
Okay, a little bit better. Little bit better.
I think
자, NGO. 자, facing off. Facing off. Yeah, a little bit better.
So the pacemaker is not in the right ventricle, that's why it's not working.
Yeah, pacemaker is not working.
Popping.
How do you think this positioning?
I think
in
this is
patient?
by far the best one and as good as it will get.
Yeah, okay.
Yeah.
Cannot be better.
자, show angiogram again. Angio again.
What we did notice
Okay.
with repositioning
Yeah, push the guide wire a little bit.
is
guide wire,
that
push it.
acute kidney injury is more common. And that's because you
Yeah, okay.
have a greater
자,
contrast
just
load.
slowly.
You know, I think this point is extraordinarily important, particularly in this case where we received 100 cc yesterday and then coronary interventions and
Just
on
moment.
top of this, this
Just moment.
contrast. And some hypotension. That is not the best
I'm
friend
doing
of
the
kidneys.
release, final release.
Yes.
The wire tension is reduced, and then I push the valve.
pigtail.
Okay, I'll do angio again. Okay, perfect. What's your opinion about this? Just when I managed the
I think that this is a
Pacemaker?
case that you can call it done once you get the pigtail out, because you probably, unless there's a lot of AR that will respond to
I know.
post-dilation, you wouldn't think to post-dilating this valve with this kind of very shallow implantation.
Because this patient has coaxial problem and complete AV lock, even though the
Exactly.
it's a very difficult case.
But very well done.
I think the best you can get, this is an anatomical issue. So retrospectively, do you think this is the type of valve, what's the best valve for this kind of anatomical issue?
Yeah. Let's hear from our T specialist, Dr. Jung.
What do you think is?
There is some paravalvular leak at the site of commissure of LCC and NCC.
So there is a little bit of paravalvular leak, that's right, but can we see the hemodynamics on the left upper panel?
Just a moment.
Yeah.
Yeah, pressure is coming back. 160 to the 50.
You still have a wire in the LV, right? Can you put a pigtail? We see the simultaneous pressures that give us a better sense of
Okay.
AR. So how much, I would like to hear from the panel, what is the opinion of, when you assess the AR, particularly in this age of minimalist, what do you use? Do you use just aortography, or do you use hemodynamics, Alan?
First, hemodynamic, the level, of course, of the diastolic pressure and the shape of the aortic curve, and then
hemodynamic
angiography.
준비 좀 해주세요.
Okay. Do you always get simultaneous pressure tracing? You don't?
No, no.
I think if you have a good echocardiography after deployment of the valve, including transthoracic echo, you can really assess, in the majority of cases, aortic regurgitation, more than grade 1 or not. Sometimes you should use hemodynamics sometimes, but in the majority of cases, good ADT is enough.
We generally use hemodynamics heavily because it's cheap and it's very quick. Just putting a pigtail catheter in and taking the wire out also improves the transvalvular appearance also. So the different practices.
I have a question about ACT during the procedure. In my center, we always check ACT before implanting the valve, just to be sure that we are really on top of good anticoagulation. So what is the opinion of the panel?
Yeah, we always check that as well at ACT, because requirement for heparin is different from patient to patient. It's really critically important. What was do you check the ACT in the lab?
ACT, we checked the ACT. It's more than 300. We didn't give heparin. So unluckily, the guide wire is just next to the strut. So when you cross the valve,
I wouldn't spend too much time in there.
It may be
This
damaged.
tenuous position, I don't know.
You should push the wire in order to have no problem with the core valve, because you see there is some interaction between the core valve and the wire.
Yeah, I think
So
it's
if you
stuck
push
there.
the wire before pushing the
Yeah, it's
catheter,
dangerous. Yeah, to do
You just want to make sure that you don't get tangled up there when you're taking your wire out also.
Just a moment.
I think it's very important because if you remove the Safari wire without protection, there is a risk of embolization of the valve.
Yeah.
Yeah, we remove the supply wire and then change into another wire.
Dr. Zhang, you better
Yeah, there we
use
go.
the exchange the soft wire.
Okay, so we are.
Okay. I wouldn't go back in, right?
Just when we the implant view. Implant view. Not implant. Three cuspid. Cranial 10 area. So cranial 10 area 11. So actually this is 3 cuspid. So I'm doing the aortogram. Yeah, no PBL. Actually, the depth is ideal.
Yeah, very well done. It was a very difficult case. You really stayed with it and recaptured twice. And I think on the third attempt, you implanted very shallow. We congratulate you, and I think.
I think that the last question will be the policy on leaving the pacemaker because the patient.
Third-degree block. Third-degree block.
Unluckily, she currently not recovered to sinus rhythm, so we have to keep the pacemaker. But probably the depth is very shallow, so I hope the recovery of AV block will happen within several hours.
So when patient had a very early complete heart block, even if he recovers later on, how long do you keep the patient in the hospital? It's not very easy to decide to send these patients home, isn't it? Because the AV block occurs so early and then maintained throughout the procedure. I'm not sure that if we can let him go without a pacemaker.
I
huh?
think he will get a pacemaker now
Yeah.
because he had the AV block, yes, as you said, very early, and why wait with the pacing lead for 2 days? I
Right.
think.
That's any for this self-expandable, any chance for the recovery? I saw there's a pretty small chance for the AV block with this kind of.
Yes. Any comments?
Yeah, I mean, early heart block like that almost always results in a pacemaker. And if you follow these patients up, a lot of them are not using their pacemaker down the track. But it's impossible to predict. So you find yourself implanting pacemakers in these patients.
Yes. Well, thank you very much for a wonderful case, very educational for all of us. Thank you indeed for your expertise.
Okay, thank you for sharing case with me. So it's the first time I do the 3 times of recapture and repositioning, but very interesting case. It's very useful to me and our team. Thank you. Thank you very much.
Thank you very much.
Hi, Dr. Kim.
Hi.
This is
How
Jay.
are you?
Good. So right now we have a second live cases from National. So Seoul National University, and the operator is Dr. Kim, and second operator Dr. Yang and Dr. Ham. And I just introduced a panel here. We have a moderate, it's Dr. Tusko, and we have 9 discussion. So we have a Dr. Chan and Dr. Antonov, and Dr. Hayashida, and Dr. Kim, and Dr. Lee, and Dr. Lee, and Dr. Lefrier, and Dr. Waters, Dr. Wojciechowski. So go ahead and...
Okay. Welcome to SNU Hospital. I'm H.S. Kim. My co-operators, Dr. Hanmo Yang, Dr. Jeongyu Han, all intervention faculty, and Dr. Junbin Bak, ECHO faculty, and my collaborators and specialists from company, and my beautiful mentee, fellow, Dr. Kim. Slide, please. A 74-year-old male was diagnosed as AS 10 years ago. Against medical advice, he did not receive regular follow-up for 7 years and visited SNU Hospital ER last year due to acute heart failure with pulmonary congestion, probably fluid overload. He refused surgery, and we decided to do TAVI for him. PCI was performed in left main middle-laid lesion with 2 stents, plus diabetes and hyperlipidemia, plus medications, plus this is chest X-ray showing acute heart failure with pulmonary congestion, now recovered. ECG unremarkable, it's good sign, plus echocardiograph shows severe AS with valve area 0.6 square centimeter, mean pressure gradient 15 millimeters of mercury, peak pressure gradient 70 millimeters of mercury. You can see severe concentric LVH with thickened, immobile tricuspid aortic valve leaflet. Plus, annulus is around 20 millimeters, spacious sinus valsalva, good sign. Plus, coronary angiogram shows lesion left main bifurcation area. Plus, I treat them with stent over from left main to proximal AD. Plus, root arterography shows best angle was just simple AP. You can see the center radio-opaque shadow, dagger-shaped shadow that extends from aortic annulus down to LVOT, a severe hostile LVOT calcification. Plus, both iliac artery looks good. Plus, heart axis is good, our aortic arch is good. You can see the eccentric calcification at the annulus. Plus, tricuspid aortic valve with thickening and dense calcification. In this panel, you can see the elliptical calcified shadow at NCC that extends toward the LVOT. Plus, most important factor in this case is a huge calcium chunk extending toward the LVOT on the top of severe eccentric calcification around the annulus. Plus, thoracoabdominal CT shows there is a critical calcified stenosis at the ostium of right common iliac artery. Plus, a longitudinal section and cross-section shows MLD is about 5.2 millimeters. Marginal size. The good sign is calcification is not 360 degrees, not full moon. Plus, how about left common iliac artery? Similar lesion at the ostium of left common iliac artery. Plus, MLD is 4.7 millimeter cross-section, full moon. It's worse than right side. Thus, we decide to make a main route on the right iliac artery. Plus, for this case, I prepared two important issues. The first is how to select device among three available valves in Korea, Sapien 3, Lotus, Avatar. Before selection, I always check 6 factors. Risk of AV block, horizontal or vertical heart. If these 2 risk factors is not good, I usually prefer Sapien. The third is risk of aortic dissection due to small tortuous aorta, or risk of coronary obstruction due to low height of ostium and small space of Valsalva. These risk factors make me to select Ablator. In this case, these 4 risk factors are very low. ECG good, aortic arch is good, heart X is reasonable, coronary height is sufficient with sufficient space of Valsalva. These 4 risk factors are relatively low in this case. In contrast, risk of leakage due to annulus calcification, risk of leakage and tear due to alveolar calcification is important. In this case, I usually choose Lotus valve to make the efficacy and safety. Unfortunately, Lotus valves are not available in Korea at the present moment due to recall of the company. Thus, I have to choose Sapien versus Avatar. Plus, I focus on AV calcification. It is predictive of leakage, efficacy after TAVI. There are 2 factors to determine leakage: total calcium burden and eccentricity. In our analysis of series of our patients, we already determined cutoff value to predict severe leakage. Total calcium is about 750 cubic millimeters. Eccentricity based on leaflet, 224. By partition method that we recently developed, more sensitive, more predictable, 270. In this case, total 1400. Leaflet-based by eccentricity, more than 500. By partition method, around 500. Far greater than cutoff value, suggesting heavy calcification with asymmetric distribution, prediction, high risk of leakage. Thus, I chose Sapien 3 Plus because it has outer skirt to reduce leakage. Plus, the other issue is ideal oversizing index. Bigger the valve, less the leakage. This is data from partner Sapien experience. We can see tight association between undersizing, oversizing, and instance of severe leakage. If we perform undersizing, higher prevalence of severe leakage. While we perform adequate oversizing, we can significantly reduce instance of leakage. Plus, there are 2 different methods for oversizing index. Area-based calculation used in Edwards Life Science, perimeter-based calculation used in Medtronic. Regardless of morphology of annulus, perfect circle, ovoid annulus, always the digit by area-based calculation is 2-fold higher. About 20% corresponds to 10% of perimeter oversizing. Thus, if you see the oversizing index, please check the method to calculate that index. Plus, these are ideal oversizing index for 3 different valves. Sapien 3 depend on area-derived method. Either value is less than 20%. In this case, 10%. Avatar, depending on perimeter-derived method, ideal range is less than 20%. In this case, 17%. So all adequate. Plus, I chose Sapien 3. The regular inflation leads to 10% oversizing. But I'm concerned about the big dagger-shaped alveolar calcification. For the safety, I'd like to reduce oversize index down to 5% by 1 cc on the field inflation. In such a way, we can manipulate oversize index with SAPIEN 3. Plus, to summarize my strategy for this case, choice of valve, SAPIEN 3, to reduce leakage around alveolar calcification. Oversize index, to reduce the risk of tear, I try to underfill by 1 cc. Another issue in this case is critical stenosis at the artery. So I'd like to buginate using 18 French sheath dilate because our diameter of 14 French commander system of SAPIEN is actually 18 French. Plus, is there any comment or question?
Dr. Kim, thank you very much for a great summary and also the discussion about the choice of the valve and the sizing. I think the two issues on this is mainly because of subvalvular calcification. I think the panel probably all agreed. So because of this big calcification, I think you already discussed the two issues. One is what type of valve is the most appropriate for this type of calcification, and the second is the oversize. I think you really emphasize the 2 points. I just a quick ask the panel. Anyone comments on the choose of valve and the oversize?
I don't remember the age of the patient, but I think we have always to make a balance between the risk of rupture, which is usually fatal, and the risk of paravalvular regurgitation, which is probably acceptable if the patient is very old. So that's why I was asking about age, when you prefer to have AR grade
75
2
years old.
than this. This one is young, so you don't want to have AR. Okay, there is a high risk of annular rupture so in this patient, but by decreasing the volume, maybe I would have decreased a little more by 2 cc at least, but
2 cc?
we'll see. I don't know what the other will say.
Another issue is I think I'm not sure the other comments. Any comments from panelists? And for the S3 valve, they are really precaution to reduce the volume, especially reduce the volume significantly compared to the XT valve. So I don't know, is there any usually you try to reduce?
Let's say 1.5 less between 1 and 2. No, I fully agree that the risk of annular structure is very high. So we should have a ratio between the valve diameter and the calculated average annulus diameter of 1, no more, because more there is really a big risk. So I make the calculation during the presentation. It's the ratio, if you have a nominal inflation, it's 1.6. So if you decrease by 1.5 cc, it will be about a ratio of 1. So then the risk is relatively low.
Yeah, I will go to 1.5, even 2. You can always post-dilate.
I agree. I would intend to reduce more, and then you can decide as the increase the size. That's always as a safe in this kind of situation. Okay, because of time, I think you go ahead.
Let me show the first angio. Angio, please. We always puncture the common femoral artery on the fluoroscopic guidance, plus. And I first passed 14 French dilator, not difficult, plus. Next, 16 French dilator, not difficult, plus. 18 French dilator, a little bit friction, but possible, plus. Then I introduce 14 French commander system, plus. Root arterography once again shows the AP angle would be best, and we can see the LVOT linear classification, plus. I passed straight wire from aorta to LV. Plus, introduce catheter, change, curved wire, plus, pigtail, plus. And we check the double tracing of the both chambers pressure. As you can see, the pressure here is a huge pressure the gradient. Peak pressure of LV is about 200, while peak pressure of aorta is 155. You can see the delayed onset of systolic phase of aortic pressure, suggesting severe AS. Then we are going to insert suffering wire into LV. Okay. Oreo, table. Okay. A little bit. Best angle. Okay. Valve, is the valve prepared? Not yet? Ready? Okay, give me. Listen, I skip dilatation. So I always, if the stenosis is too severe, too tight, to pass the device,
Do you do
I
a
perform pre-deal.
do you
But
do a BAV
otherwise,
first?
I do not perform pre-deal.
Dr. King, in this case, do you do a BAV first?
Not.
Can you show the amount of
Direction which I
contrast that you have
I
in the
just
syringe?
want to ask a panelist opinion. In this case, do you think a BAV is helpful in terms to assess the sizing or the behavior of the interaction between the balloon and the aortic wall annulus?
I will not use BAV in this case. I think there is not too much calcification. The only problem is calcification in the left ventricle, which can be a problem if you do predilatation and then, I don't do BAV.
I do like Thierry, I wouldn't do it because also of the discalcification and the risk of rupture.
So I moved the valve frame.
Can you show us the amount of contrast that you have in the syringe?
Okay. I'm sorry?
Can you show us the amount of contrast that is in the syringe?
Do you mean the inflation volume?
Yeah.
How much?
You can see it on the
How much
syringe.
is the volume?
22. 160 on the field.
22 milliliter with 1 milliliter on the film. Okay. 자, 루트, 아우팅 아치를 좀. Wire stay.
So reduced by 160.
What is the size of the S3? 26?
Yeah, 26.
Okay.
자자고요.
So -1 is less than 1 millimeter less. To have 1 millimeter less, you have to remove 2 cc.
That's why I should
Yes.
suggest 1.5.
It's difficult to predict the diameter, true diameter, so by 160, sometimes it could be a...
혈압 좀 올렸나? 100밖에 안 되는데.
Dr. King, can you explain what are you doing right now?
I retrieved the pushing catheter. Okay. Testing.
I think
Test
very
it.
slow inflation is the key to
Yeah.
avoid the perforation.
Also shows how easily the valve crossed without
입으로 쭉. 자,
pre-dilatation.
스네 갑니다. 스네.
There was-
Shoot.
There's really no difficulty crossing without
How about the
pre-dilatation.
level? A little bit high, but on the field, and there's a bit calcification. I'd like to try to high implantation.
Yeah, I
It's a little
completely
bit
agree.
high.
I think this is not too high for this patient. I think you'll just
Okay.
try to stay just at the annulus in this case.
Just once again, 스네. Shoot. Okay. So I start the inflation, pacing on, dive, 자, inflation,
Inflation. 1, 2, 3, 4,
full,
4.
1,000, 2,000, 3,000, 4,000, 5,000, deflation, pacing off,
Very well
Looks
placed.
good. So it looks like a pretty high implantation here.
T,
예. 0시 방향이 조금
T, please. Okay.
0시 방향에 파라벨릭 있고 있습니다.
Cross section.
What's the blood pressure right now? Cannot see it.
About 100.
Blood pressure
Yeah.
is good. Pulse pressure is good.
There is trivial to mark parabolic is at 12 o'clock.
What do you think of the paravalve leak?
Mild degree and just a single one, and the degree can be measured as mild.
Cross section, please.
It's very focal and related to
Yeah.
that area of
Yeah.
calcification on the aorta.
So
matrix.
the leakage point is just between NCC and LCC.
Yeah, I agree.
So right at
So
12.
exactly coincident with the Elliott calcification.
Would you do a angiogram now?
Yeah, okay. So remove the T
Yeah.
probe. 약간 카운터 해야지. tangential view. Okay, that's good. Then I manipulate the wire, a little bit pull, to locate the wire in the center of the valve to minimize the wire bias.
You know, another option in this case when you're evaluating AR is just to put a pigtail that will take care of the wire bias, and you'll also have simultaneous
Yeah.
pressures to give you more confidence about AR.
Yeah, first just see the leakage, okay? See that? Shoot.
Don't you think there is some underexpansion on the left side, on the stent, when you look at the stent? No?
Yes, I wonder.
Definitely
I think
see
it's
the
because that's
impact of the calcium.
Yes.
That's because of
아래요,
calcification.
아래요.
It
But
explains
I
the
will not rely on this aortography when the wire is in place.
It's difficult. Post-dilatation may not take away that AR because you've got that nodule there.
And certainly the risk.
Yeah.
I have to be convinced that this
why-
needs post-dilation. I mean,
stay
this is a
okay.
high-risk case.
Yes.
I agree.
와이 좀 넣고. Okay. Okay, check once again in different projection. Okay, 스네 준비. 스네. Shoot.
I think it looks pretty
Before,
good.
before deciding exchange of stiff wire to pigtail, we have to determine to perform additional ballooning with 1 cc addition, or just exchange to pigtail and see the true regurgitation or AL index?
You know, I think that
What do you recommend?
I think that you have at most 1 to 2 plus AR, right? It doesn't look like it is even full 2 plus. A bit more, of course, in LAO as usual. This is a high risk for perforation, considerably high risk for perforation. I would just do everything before I even start thinking about post-dilation in this case.
I agree, and you can see the valves already have quite a waste. That's indicated this calcification. You quite, as for the post dilatation with this kind of subvalvular calcification, I think it's pretty high risk, and it's very focal pelvic leak. That's usually is not indicated. This expansion problems because there's a local calcification problem because the leak is very focal and only one spot. So that's usually due to the calcification rather than the expansion issue.
And also, Dr. Darren Walters just minutes ago made the comment rightfully that many times when you post-dilate these valves with this kind of calcification, they don't get better. AR doesn't get better necessarily.
I agree. In our data also, the quality of calcification predict the response after post-dilatation. If the concentric calcification, we can reduce leakage by additional ballooning. But the calcification is eccentric, post-ballooning does not help.
Yeah, I think this is mild, and I would stop at this point.
I would take the wire out and then check the echo.
Okay. 자, 와이어 좀 스테이하고.
Sometimes with S3, unlike Sapien, also the early time, another 5-10 minutes help as well. Yeah. Sometimes.
The skirt fills, I
Yes.
think, the time.
픽테일. 자, 작은 화면에 프레쉬 말고 에코를 에코 좀 보여주죠. 네, 오케이. 에코를 잡고 작은 화면에 에코를 좀 보여주죠.
한 번만 더 말씀해 주십시오. 에코로.
크로스 섹션 한번 다시 보여줘.
예.
There's trend of reducing leakage as time passes. 자, 프레쉬 좀 할게요. 이때는 아까 인플레이션하는 필름을 보여줘. 지루하니까. 네? 마이너스 해가지고.
So is there any
Minus.
reduction of PPL on echocardiography?
Yeah, slightly decreased amount was observed.
Can you give the transaortic gradient by echo?
I'll try.
Because I think this is something that may push you to post-dilate more than the PVL, which is not very important.
Can you give a comment on echo?
Transgastric view is difficult to be acquired, so it's difficult to assess the transvalvular pressure with TE in
But-
this patient.
As you can see, the pressure profile, pressure 보여주고, pressure. There's no gradient between two chambers, while there is a wide pulse pressure suggesting regurgitation. AR index.
잘 안 나오네.
자, AR 인덱스 보여주고 AR index is about 23. Mild to moderate degree regurgitation. 다시 그전 angio T 잘 안 보여주나?
지금 말씀하신 게 트랜스 게스트릭뷰로 프레셔를 좀 재단해
말고 프레셔는 아까 없다고 차에 있다 있고.
예, 알겠습니다.
Color Doppler please.
예.
Dr. Kim, do you usually perform a final aortogram?
Of
Or
course.
Of course.
T를 크게, T 뷰를 크게, 엔주하고 스위치. 스위치만 하면 되는데. 참. 자, T 보입니다. T 잘 잡아주세요.
네.
There is one focal regurgitation at 12 o'clock that corresponds to alveolar calcification. 자, 다 했죠. 다 했어.
What everybody think that this leakage.
So what to do? Maybe we'll start from one end, huh?
I
Okay,
wouldn't, I
let's
wouldn't
check
touch
the
it.
regurgitation. 자,
So
P
we're go-
빼고, angio.
Dr. Kim, we're going to poll the panel for you. I think we're going to start on our leftmost side by Dr. Wojciechowski.
I wouldn't do
Okay.
anything more.
Okay, one vote for don't do anything.
Okay, let me show you the angio root arterography. The cine. Shoot.
How pigtails it?
The
Small.
pigtail is still central,
Yep.
they're still in the album. Without the
So
pigtail.
I removed the LV catheter to accurately assess the regurgitation AP.
So what is your vote there and over there?
Look, I don't think you're going to affect this regurgitation by any further intervention. And, you know, I
Okay.
think it's acceptable for a
심하다.
very
풀고.
eccentric and
조금 더 풀고. Okay.
nodular calcification of the aorta mitral curtain. So I think it's a good result for the anatomy.
What do you
Sure.
think?
Smiled.
Dr. John?
Dr. Chan?
Do we have to stop at this moment, at this step, to avoid the risk of tear? LAO 쪽으로.
Helen, what do you suggest?
It's very difficult because, of course, you prefer to have less regurgitation, but if you have a rupture, you,
Okay.
I don't know. I would keep it like that probably. But of course, usually you have a better result with the S3, so a little disappointing, but the risk of rupture is very high. So.
Other color.
One strategy in this situation is if there is a problem with AR post is percutaneous closure because it's a very focal leak and it would be potentially amenable to a percutaneous device-based closure. But I don't think dilating it's going to help.
What is the
Okay,
vote
we
here?
comment
Let's go.
on this side.
Considering the SAPIEN 3, we just waiting for it maybe the probable regurgitation is getting the better. So it is not
Getting better?
So no.
Yeah,
No,
no,
touch, huh?
yeah, leave it alone.
Further action.
What do you think?
I agree
Minus.
with the no touch.
No touch. Here?
No touch.
No touch, huh? What about
Minus.
Dr. Lee over there? you gotta tell her.
Minus.
But
Plus.
I think it's very important to reassess this PVL within few days, and if it's more than grade 1, maybe you should close it percutaneously.
And if patient is symptomatic. If patient is symptomatic.
Of course,
and
of
not
course.
feeling well, yeah.
Dr. Hayashida, you have a lot of experience. What do you think?
I think for this case, we cannot expand anymore because of the risk of the high risk of perforation. And I would like to ask Dr. Kim, how much degree of pre-procedural AR does this patient have before procedure?
probably greater than the AR after TAVI, mild to moderate. Now the AR is mild, a little bit reduced. AR index is reduced compared with pre-TAVI procedure. Thus, stenosis as well as regurgitation was corrected simultaneously by TAVI.
I think if the degree of AR is reduced by TAVI, you have done good things to the patient. So I think it's okay.
Yeah, I think that the French study, that French registry showed that indeed the pre-procedure AR is somewhat almost protected.
I think that I just give the opinion from panelists. I think everyone agree. I think this is acceptable and a high risk for redilatation. My personal comments, I think I agree. This is a regurgitation to me is pretty mild, I would say. I don't think there were significant major effect on the patient outcomes. Looks pretty. As an angiogram, we at our center we usually don't do the aortogram for the AI because it's not really reliable on the aortogram. So we try to cut down the aortogram as much as possible based on the echo, basically. So what are your comments?
Service for the audience during live demonstration. I usually not perform such kind of multiple root arterography blast, but I performed root arterography 3 times, 3 different angles, to show the nature and degree of AR more accurately.
I think this is a great result. And if you look at the aortogram carefully, on the non-conic cuspid side, there's sinus valsalva, there's no lumen there. You see the contrast, there's no contrast down there, so it's pretty full. So for the redilatation, I think is really concerning. So I think that this is a very acceptable outcomes for this kind of high risk and non-symmetrical calcification aortic stenosis. I think a great result and good position. I would say congratulations.
There's a nice saying in English, very applicable here, the enemy of the good is perfection. So.
It's a really good word. Thank you very much. I try to imply and deploy the valve as high as possible. I'm happy to get such a position, just avoiding the risk of pushing the LVOT calcification and risk of tear. Because as you can see, the lower edge valve frame is really high. The remaining lower part of LV calcification is free from valve frame pressure. So I try to, usually when such kind of lesion is met, I usually try to deploy the valve as high as possible for the safety.
Great. I think excellent result. I agree, this is a perfect position to me. Thank you very much. I think congratulations for this great success. Thanks.
Thank you very much.
All right, we're going to move on to the featured lectures. The first one is Young-Min Ahn from Asan Medical Center will present bicuspid aortic stenosis, future perspective of TAVR.
Yes, thank you, Chairman. I'm Dr. Ahn from Asan Medical Centers. My topic is bicuspid aortic valve. Actually, the previous, my live demonstration was bicuspid TAVR. So this year, the inoperable patient, high-risk patient turned to guideline 1A, intermediate risk 2. So we like to move down and down in low-risk patient, younger patient. Then we have to know the bicuspid aortic valve disease. Actually, bicuspid aortic valve is very common, 1 or 2% in general population, and aortic valve stenosis is the most frequent complication. So many Western doctors ask us that the really high incidence of bicuspid in Asian, but I think in the Western, bicuspid is a very high incidence. look at this. This data came from United States, Baylor University. Overall, isolated AVR patient in autopsy, incidence of bicuspid aortic valve disease is almost half. And TAVR age between the 71 to 80, 42%, 81 to 90, 28%. So incidence of bicuspid is higher than our expectation, even in Western and Eastern Asia. However, bicuspid aortic valve have very ugly anatomical characteristics. Annular eccentricity, asymmetricity, unequally sized leaflet, calcified lappe, in addition concomitant aortopathy. So many diverse spectrum of aortic valve disease, different lappe and different involvement aorta. In addition, more important thing is the lack of standardized valve sizing. Someone favoring annular sizing, someone supraannular sizing, undersizing, or finally we decided sizing after ballooning. However, I like to say there is no rules case by case, but we have to avoid oversizing, particularly in heavily calcified bicuspid aortic valve. Safety first. This is data from the Cleveland Clinic. They evaluated 200 patients who have CT evaluation before SAVR for the bicuspid aortic valve. Regarding the annulus area, only less than 10% of bicuspid aortic valve annuli would not fit the current available valve stent. So regarding the size, most bicuspid aortic valve can be treated by current available TAVR device. But many concerns regarding procedure, elliptical deployment, durability, residual aortic regurgitation, annulus rupture, coronary obstruction, and aortic complication. So many random trials, but many excluded the bicuspid aortic valve in major trial exclusion criteria. So the many registry, real-world registry, the frequency of bicuspid aortic valve in TAVR registry is very low compared to the SAVR registry. Look at age 81 to 90 years, definitely TAVR age, bicuspid aortic valve frequency is 28%. Data came from United States, but real-world registry, Poland registry, France, Asian, Italy, German, United States, less than 7%. But the only one data coming from the China, bicuspid aortic valve incidence is 60%. I think this is not due to ethnicity, but due to age. Mean age is 74, so age would be one important factor to decide the incidence of bicuspid aortic valve. So the very limited data regarding TAVR for bicuspid aortic valve, but there is some serious concern, high risk of permanent pacemaker implantation, and high incidence of more than mild paravalvular leakage. Most of the bicuspid aortic valve treated by self-expandable device rather than balloon expandable device. However, look at this. Ironically, the first patient who received TAVR in the world, first in-man TAVR, was done in bicuspid aortic valve. 57-year-old, severely calcified bicuspid aortic valve. So I'd like to talk about TAVR for bicuspid aortic valve, really risky regarding the mortality, and then compared to the early generation device, new generation device improved the outcomes of bicuspid TAVR. This is data from China. They follow up the echocardiogram 1 month, 3 months, 6 months, 1 year. There is no increase of delta pressure gradient between baseline to 1 month, 3 months, 6 months, 1 year between bicuspid, tricuspid. In addition, Dr. Yun published this data this year compared to the bicuspid, compared to tricuspid, bicuspid TAVR did not increase the mortality. At 2 years, mortality is very similar. P-value is not significant. However, for the patient who receive TAVR with bicuspid aortic valve have high risk of aortic root injury and high risk of paravalvular leakage. This is a big problem. So we have a new generation device. So what changed? Look at this, the 79-year-old chest pain, bicuspid aortic valve. So I put the absolute R. I think it's acceptable result. So 78 bicuspid aortic valve. So I put the SAPIEN 329 4cc overfill. Final result acceptable. So I think if we do the TAVR using updated new device, the result would be good in very selected patient. So look at we compare the 200 early generation, 100 new generation device. So 30-day outcomes, paravalvular leakage more than moderate, definitely decreased. New pacemaker, but no difference. Annular rupture decreased. So device success rate increased. Mortality rate, no difference. Safety endpoint, no difference. So paravalvular leakage in new generation device, SAPIEN 3, no moderate to severe paravalvular leakage. Annular rupture before early generation devices, particularly SAPIEN XT, 4.6, very high instance of annular rupture. But the new generation device decreased, but still SAPIEN 3, 1.1, but very rare. Second valve implantation, very rare. New pacemaker implantation, but still more than 10%, or almost 20%. So this is my summary. TAVR for tricuspid and bicuspid aortic valve stenosis showed a similar long-term mortality up to 2 years. Lower device success rate with early device, annular rupture with the SAPIEN, paravalvular leakage with the core valve. New device showed excellent outcomes, no moderate or severe paravalvular leakage, improved device success. However, we have to consider the still relatively high risk of permanent pacemakers. We do the young patient, we have to consider this aspect. So this study suggested that the selected patient with bicuspid aortic valve stenosis would be a candidate of TAVR with a better device. Thank you for your attention.
Okay, next lecturer is Dr. Husted Siewert. He will give a lecture on TAVI for low risk and the young patient. I think this is a controversial topic. Thank you.
Thank you very much, and thanks to the organizers for inviting me. So as you all know, over the last 15 years, TAVI has really become a routine procedure in more than 65 countries around the world. There are more than 300,000 patients treated worldwide, more than 100,000 per year. The annual growth rate is more than 20%, and in some countries, like in Germany, more TAVIs are currently performed than surgical valve replacements. And without approval and reimbursement problems, TAVI would grow even faster. And actually, as you have seen today during the live cases, there is a trend towards lower surgical risk patients. This is in the SDS ACC TVT registry, as well as in the UK registry, as also in the German registry. So what means low risk? According to the intermediate risk trials in partner 2A, low risk means STS score below 4. In the partner 3, SI also below 4, in the core valve US pivotal also below 4, and in the SOTAVI trial, low risk means less than 3. So what is a younger patient? Any patient who is younger than you. And as you all know, this is obviously irrespective of your own age. So what does it mean, low risk and younger patients? You could have a high risk and an old patient. That is the typical partner 1 patient. Then you could have a low risk and old patient. That could be an 85-year-old male without any comorbidities, and that patient has a Euro score of 2.7. You could also have a high risk and young patient, and that could be a 50-year-old patient, prior CABG, chronic kidney disease, pulmonary arterial hypertension, COPD, reduced ejection fraction, and PAD, and that patient has a Euroscore of 40. And of course, you can have a low risk in young patient, that would be a 50-year-old without any comorbidities, and that patient would have a Euroscore 1. So you can see that really young and low risk are independent factors, and they may be combined or they may be not combined. What was the 30-day TAVR mortality in the intermediate risk studies? The predicted mortality in these trials was above 3 or above 4. In partner 2A, it was 3.9. In partner S3I was 1.1. CoreValve US Pivotal 3.3, so TAVI 2.2. That means the observed TAVR mortality in intermediate surgical risk patients was already lower than the predicted surgical mortality. When you look at the meta-analysis, TAVR and SAVR, you can see that TAVR provides a statistically significant 30% relative risk reduction of death from any cause, and this was a class effect independent of valve type. Current ACC and AHA guidelines clearly recommend surgery in low-risk patients, as you see here. Lower surgical risk is a class 1 for surgical aortic valve replacement. Are there any trials in very low surgical risk patients, which means an STS score below 4? Well, to some degree, there's the NOTION trial, but this is actually not a low-risk trial. It's an all-comer population. And you can see the result of the baseline characteristics of these trials. You can see that the Euroscore was 8, so it's actually not really low risk. STS score was 3 or 3.1. You know the results. There was a very strong trend towards better outcome with TAVI regarding the primary endpoint, death, stroke, myocardial infarction. And there was also a very strong trend towards better outcome with TAVI regarding death from any cause. When you look at the 30-day, most parameters were actually in favor of TAVR. Only pacemaker rate was higher after surgical valve implantation. So this, again, was a trial in all comers. More than 80% of the patients had been at low surgical risk. The trial was underpowered to show a significant difference in death, stroke, MI after 1 year, which was the primary endpoint. However, there was a strong trend in favor of TAVR, and 30-day results showed superiority of TAVR regarding most parameters. In the NOTION trial, all comers had been randomized. Can we expect similar results in low surgical risk patients? There's actually a sub-analysis of the NOTION trial. Those patients with an STS score below 4, and you can see there's still a trend towards better result with TAVR. So the NOTION trial recruited patients between December 2009 and April 2013. What has changed since this time period? I think it's fair to say that there had been no relevant change in surgical techniques or outcomes over the last 5 to 10 years. However, there have been major improvements in TAVR. Increased operator experience is probably the most important one. The procedure has become much more simpler and easier. There are new valves, new technologies, vascular closure devices, embolic protection devices. The randomized trials in high and intermediate surgical risk are already outdated. And these are the new valves which had not been available at the time when the NOTION trial recruited patients. Let's go through the list of possible improvement in TAVR. Feasibility, stroke, need for permanent pacemaker, vascular complications, paravalvular leak, long-term durability. What's about feasibility? There is no question that with newer valves, TAVI has become a much more feasible procedure. Every single step has been completely standardized. It's a 1-hour procedure. Technical success rate is more than 98%. It is as easy as PCI at least. What's about stroke? Stroke, the weighted average with the newer valves is 3.5%. That's actually not too much different from the older valves where it was 4%. But it started at a low rate anyway. You can see no improvement in stroke rate, but stroke rate was only about 2.1 and 2.6% in these trials. When you compare this actually with the PARTNER 2 trial compared with the SAPIEN 3 trial, this is TAVR, this is surgery, very low rates of stroke in TAVR anyway. When you look at the CoreValve SOTAVI trials, disabling stroke, better results with TAVR compared to surgery. What's about need for pacemakers? Well, this really depends upon the device, and actually the results are not bad with the newer valves, but with the exception of Lotus, which still has a very high pacemaker rate. Old waves, the average rate was 11%, and with the new one, it's between 3 and 20%, depending upon the device. Vascular complications, that's really a major improvement. Major vascular complications occur now in less than 5%, and this is a dramatic reduction. This has also an influence on the mortality and disabling complications. What's about paravalvular leak? Lower rate compared to all valves. You can see the rate of significant paravalvular leak is below 5% in most of these trials. Older valves had more than 10%. When you look at partner 2, SAPIEN 3, 3.7% significant paravalvular leak. What's about long-term durability? And this is really the key factor for younger patients because they need the valve longer than elderly patients. Actually, there are conflicting observations. You know the results from partner with good long-term durability, but there had also been some reports of degenerating valves after 5, 6, 7, 8 years. However, we have to keep in mind that in case of leaflet degeneration, we have the option of valve-in-valve. In any case, all restrictions like Euroscore has to be more than 20, STS score has to be more than 10, age has to be more than 80, a heart team decision is required, have no scientific background, are not validated, are driven by economical and political considerations. With the currently available data, should we consider TAVR in a patient with low surgical risk? Yes, at least in a free and rich country with no reimbursement issues, we should discuss the pros and cons individually with the patient. No, in all the less free countries where reimbursement, approval, regulatory and guidelines and other issues. There's a number of low surgical risks trying on the way. Medtronic low risk, partner 3, UK TAVI and Notion 2. What could be the outcome of these trials? It could be, for example, mortality treatment A, 1.5%, mortality treatment B, 0.9%. This could be a statistically highly significant, but maybe clinically not very relevant difference. A study result which looks like a clear signal for scientists, doctors, and regulatory may look completely different in the view of the patient. Summary and conclusion, TAVI is accepted as standard of therapy in patients who cannot be operated. It is also accepted as alternative to surgery in high and intermediate surgical risk patients. TAVI is on a rise, and with new valves and new technology every year, patients always prefer less invasive treatment options. It is only a question of time until TAVI will become an alternative also in low-risk surgical patients. Thank you very much for your attention.
Thank you very much indeed for this very convincing and elegant lecture. The next is Dr. Dukwo Park. How do we choose specific valve types in our TAVR practice?
Okay, thank you, Murat. My topic is definitely the subjective topic rather than objective topic. It's how do we choose a specific valve type in our TAVR practice? So in current standard of TAVR in our country, in SAPIEN 3, Evolut R, Lotus was Vicor. We are now available SAPIEN 3 in Evolut R. So, and look at this slide shows TAVR status in our country. Is up to recently, is overall, is 830 cases was treated. It was TAVR last 7 years, and overall is 60% was treated with balloon expandable. Is 40% is self-expandable stent. Look at our the SAPIEN 3 in Korea. Is size was 40%, 26 is 50%, 29 is 13%. Is SAPIEN 3 is used 37%. Looking the core valve is much larger, 23 10%, 26 37%, 29 is 48%, 31 is 5%. Evolut R was the user. How do we choose optimal valve type selection? Definitely this is subjective the question. So at first we should understand the features and the limitation of a specific TAVR device. Looking at the circulation of the annulus, balloon expandable type, and the processes remodels the annulus that is a self-expandable type. The annulus remodels the processes like active remodeling versus passive remodeling. It shows the more circular in the balloon expandable, is less circular, is a self-expandable prosthesis. So size selection for balloon expandable SAPIEN 3, and we definitely use the area oversizing is percent, And there is the diagram of the valve size expand is relatively narrow compared to the evolute R. And looking at some data is with the development of the device and with the more the oversizing as the associated the marked reduction of the paravalvular leaks that we're going to do about more than 10% is a moderate to severe AR is less than 5%. So oversizing, however, is definitely the independent predictor of the injury of the pacemaker rate. Is extremely oversizing was associated higher incidence of the permanent pacemaker implantation rate. So, and the TCTAP is our top center is the optimal target for area oversizing SAPIEN 3 is 5 up to 15, less than 20. Is how about the size selection for self-expandable evolute R? So the perimeter oversizing is that we use is evolute R can be completely recaptured in any the emergency situation, and is a taper safe of the frame and the coronary access can be achieved through the strut of the frame compared to the stand. So the evolute R is a broad coverage of size compared to SAPIEN, and indicated the size range is the range was more wider rather than the SAPIEN 3, and the less paravalvular leak with evolute R with the previous core valve, but the mild is still the significant, and the perimeter oversizing definitely associated with a lower the incidence of the paravalvular leak. So we're going to do more than 20% is the paravalvular leak less than 5%. So perimeter oversizing, however, is associated with a pacemaker insertion rate. Still, the evolute R is 20% was usually received the permanent pacemaker. Manufacturer also recommendation is a more larger. The oversizing is up to 30%. So choose a large one. So in some borderline case, and in borderline case, SAPIEN 3 case, so we're going to choose a small size, and then do the oversizing, and the evolute R, we choose the bigger sizes initially. So how do you choose valve type balloon expandable versus self-expandable is type of practice. Mostly, I think, depending on the physician's preference. There was no clear cut. It depends on personal experience, availability of device, clinical and the anatomic situation. Until recently, there is no clear-cut criteria favoring specific one type of device. That is our Aspen Medical Center valve selection. The matter is the size matters. The selected valve with the size in the safety zone. Prefer SAPIEN 3, less annular, subannular calcification. Annulus eccentric, less the eccentric. We select SAPIEN, much eccentric is select evolute, and also the high comorbidity, severe heart failure, to avoid the rapid ventricular phasing, because the valve, low calcium height, larger annulus, smaller peripheral vessel. We select evolute R. Is looking at this slide, is definitely unfair game for evolute R in the top center. And looking at the lowest delivery profile, the peripheral vessel was small. We select the core valve is more than 5.5. Is anatomically is okay. We much select the SAPIEN 3. This is our typical case, 81. Year female and severe AS, and the ejection pressure 38, and the calcium score is 339. The millimeters, the scale is the calcium volume. So the peripheral was right is 5.3, is left is 3.8, and we select on the basis of patient clinical characteristic and the peripheral vessel. We select evolute R, and successfully implanted evolute R. There is some mild the paravalvular leak. So what about comparative data of the balloon expandable versus self-expandable? Just one random trial. It's a choice trial. It's a randomization. SAPIEN XT 120, core valve 120. Overall result is nearly similar to our peeling in real practice. Is a choice trial. Is a pre-balloon dilation is 100%, self-expandable 88%, and looking at the size is a much bigger size with the self-expandable valve. And the implant of the more than 2 valve is much higher with the self-expandable stand, and the balloon post-dilation, the rate is much, much higher with self-expandable stent. And also looking at the final AR and angiographic measure, the echocardiographic measure, there is a moderate to severe AR, much, much common with the co-valve system rather than balloon expandable system. So choice trial is device success rate is much the better for balloon expandable rather than self-expandable stent. New permanent pacemaker, the 17%, 37% is a much, much higher self-expandable. In our practice nowadays, after adoption of SAPIEN 3, permanent pacemaker rate is less than 5%, with the average R is up to 15%. So this is our the experience of a 300 patients. Is transfemoral, balloon expandable 61, self-expandable 39. I look at the baseline characteristic, no difference of the age. STS score was comparable, slightly higher with the SAPIEN the group. And aortic valve area was no difference. Mean gradient was no statistical difference. Bicuspid LV aortic valve is slightly higher with the core valve. Looking at the perimeter and the total calcium volume, is a perimeter is no statistical difference, but the total calcium volume is much higher with the core valve. Is looking at the procedural result, the procedural success is good for both stent. Implantation, the both valve, implantation of the two valve is 1.1, core valve 8.1, and the new permanent pacemaker 2.7 is core valve 20.7%, paravalvular rig more than moderate 8.2%, 21%. Overall result is some similar with the choice trial. It's a 1-year death of disabling stroke is no clinical difference. So in summary, how we choose a specific type of TAVR valve. Selection of a specific type of valve is based on several clinical and anatomical factors. Optimal imaging acquisition and the imaging-based personalized approach is helpful for decision-making of selection of the specific valve type. Optimal valve selection between the balloon expandable versus self-expandable, I think it may improve procedural and long-term clinical outcomes of a TAVR procedure. Thank you for your attention.
Well, thank you very much. We are right on time, and then I thank the panelists and those of you that stayed to the bitter end. Thank you very much, and we adjourn this session.